Thank you for joining us for our September coffee chat, which is focused on patient access in the States, which is why I'm joined here by my amazing colleague, Brian Warren, who is the Vice President of State Government Affairs here at BIO. And I will hand things over to him in a minute. But I would be remiss if I didn't share a little bit of information for our upcoming patient summit first. And so I will try to share my screen um, because I'm a visual person. I hope you can see the slide. Our patient summit is coming up October 26th to 28th in Washington, D.C. October 26th will be a nice reception in the evening, and then the 27th and 28th will be packed full of amazing presentations, panels, workshops, lots of opportunities for networking. We will dive a lot deeper into many of the issues that we're talking about today, as well as many other issues around patient access and innovation. I put the link to the program in on the slide, and I know Sarah is also going to send the link in the chat. It is free for patient groups and for our member companies to join us. Registration is still open, so I really hope that you all will be able to join us in Washington, D.C. in just about a month. And you'll learn a lot more about 340B and AFPs and all the other amazing things that we're here, PDAPs, all the things that we are here to talk about today. But with no further ado, Brian, may I hand it over to you to introduce the panelists? And one quick note,
Absolutely.
really quickly, Kelly Maynard from Little Hercules unfortunately fell ill, so we will have her join us in one of our future coffee chats. So if you looked at the program, unfortunately she will not be able to join us today, but it just means we have a little bit more time to dive into the other topics. Brian, the floor is yours.
Thank you, Karen. And good afternoon, everyone, or good morning if you're like me on the Western and the West Coast and it's 9 o'clock. I hope everyone's having a good Monday so far. We have a good panel here today. As Karen mentioned, Kelly's not here, but that will give us a little, and we'll miss her, but it'll give us more time with our other panelists who I know you'll all have some exciting times hearing from. So we have three panelists here today, and I'm going to go through and we'll be talking a little bit with each of them, and then hopefully we'll also have an opportunity for them all to kind of join in with discussion together. First, I wanted to turn to Ashira Vantries, who is the Director of Legal Strategy and Advocacy with the AIMED Alliance. And she's an attorney and a passionate advocate for healthcare access. She's also Athena's sister, who is a KIF-1A warrior. And as such, advocacy is very personal for her. One of the things that we wanted to talk about right now, and that Karen mentioned actually, is alternative funding programs or AFPs. And I wanted to, Ashira, thank you for joining us, first of all. And I wanted to see if you can describe a little bit about alternative funding programs, what they are for those people who might not be familiar with them, and also if you've seen different flavors of them and how they've kind of cropped up recently and how you're starting to see those trends.
Yeah, absolutely. Thanks, Brian, and thanks, Karen, for inviting me to participate in today's conversation. Like you said, my name is Ashira Vantries, and I'm the Director of Legal Strategy and Advocacy at AIMED Alliance. If you're not familiar with AIMED Alliance, our mission is to protect and enhance the rights of healthcare consumers and providers. We've been doing a lot of work in alternative funding programs over the last couple of years. And how I kind of break them up in my mind, alternative funding programs, their main goal is to identify an alternative source for the drug itself. So that's typically an international pharmacy or manufacturer's patient assistance program. And so this is different from a copay accumulator and a copay maximizer because those programs attempt to get the most amount of financial assistance available, so like actual dollars from those copay assistance programs. So that's kind of the biggest main difference we see in those two programs. We also often see accumulators, maximizers across all types of health plans. So, your individual health plan all the way up to your self-insured employer-sponsored health plan. Whereas alternative funding programs, we typically see in the large group and self-insured plans. They also are operating in a bit of a different market as well.
Thank you. I think that's great. And then can you talk a little bit more about the relationships between AFPs, accumulators and maximizers? A lot of patients get confused in this web. But can you help talk a little bit more about how they relate to each other?
Yeah, so a copay accumulator essentially says that any copay assistance that you receive by a manufacturer copay assistance program can't count towards your maximum out of so essentially they collect that money on your behalf and then they don't count it towards your cost sharing requirements. A maximizer does the same thing, but instead of just accepting the monthly amount that's necessary to get your copay that month for your medication, it looks at the total amount of copay assistance available for the year and inflates that copay to whatever that amount is divided by 12. So let's say there's $12,000 available for the whole year, that your monthly copay to $1,000. So that way the plan collects the total amount of copay assistance available rather than if your copay was only, let's say, like $200 where it wasn't getting the maximum amount. And so those two programs are really focusing on copay assistance for individuals with commercial insurance. And so alternative funding programs are also used by individuals with commercial insurance, but they attempt to apply them to these patient assistance programs, which are manufacturer-run programs for individuals who are uninsured or underinsured. And so essentially, instead of going after those dollars that they were getting from the copay assistance, they'd say, okay, let's try and actually get the product itself to the consumer, completely avoiding the typical pharmacy benefit plan. And so they're trying to either get it from that PAP where the drug is shipped directly to the consumer or through an international pharmacy.
Sounds like a series of complicated programs set up on top of the already complicated system that patients have to navigate. So that does not sound very good for patients. And can you describe more about what it means for patients and when they're caught up in these programs or when they're in the middle of them and what can it mean for them in terms of access, financials, et cetera?
Yeah, definitely. I think these programs, when a consumer first runs into them, definitely caught off guard because we know consumers with chronic conditions are very savvy and they're very thorough in enrollments. So when they're reached out by these third-party programs and said, hey, you now have a new program you have to work with, they're often caught off guard and surprised. I think they're even more surprised when the alternative funding program then tells them, if you don't work with us, you're going to be responsible for 100% the cost of this medication, which we know can be thousands of dollars a month. And this amount is not going to count towards your annual cost sharing limit. So essentially, it would be indefinite. And I think no average consumer has the money to afford that. And so, really, with no alternative, they're required to work with the alternative funding program to access their medication. And just even from the outset, the process is very challenging. Consumers can be asked to fill out a power of attorney. I've seen power of attorney requests for up to 5 years, but your health plan is only 1 year. So, why they would need authority to act on your behalf for 5 years is pretty alarming. Consumers are also often told to complete their PAP applications in an inconsistent manner. Um, so they look eligible for these programs that are for uninsured or underinsured individuals when they're actually not because they do have commercial insurance. So I think those are the kind of like logistical challenges of working with the AFP. And then once they've gone through kind of that paperwork process, there's a really good survey done by Hope Charities that found out of about 200 patients surveyed, when they're working with the AFP, they experience a delay in access to their medication of about 68 days, which is about just over 2 months. So that's a pretty substantial delay in getting access to someone's medication. And the same survey
That's
also found that of those, 25% experience negative consequences from those delays. So they're definitely very harmful programs for juries.
Yeah, that's really challenging for patients. And perhaps that's part of why you co-founded the AFP task force, with that and your personal involvement with your sister. So can you talk a little bit about what the task force does to educate patients, employers, et cetera, and how patients can get involved?
Yeah, absolutely. So the task force was created by Cancer Care and the National Bleeding Disorders Foundation, and AIMED Alliance co-chairs the advocacy working group. And really, the goal behind the task force was to put together advocacy organizations that were working on addressing alternative funding programs and identify policy solutions for them. And so we've been working with a number of stakeholders. There's dozens of patient, provider, and care groups now part of the task force, who've been working together to send letters to HHS, CSIO, the Department of Labor. And we've had really productive conversations with these agencies, trying to educate them on the problem of AFPs and the potential solutions as well. I think the biggest challenge is that we do see alternative funding programs in the employer-sponsored health plan space. And so it's obviously very difficult for consumers to speak out against their employer who are using these programs. But there's definitely opportunities for patients and individuals who have been impacted by these programs to reach out to the task force and figure out ways to share their stories in which they're comfortable.
Fantastic. So good news on the AFP front. That's the first time we've had a little bit of good news, I guess, so far this morning. But AFPs this year were banned in Indiana and Maryland as part of legislative efforts related to that was also prohibiting maximizers and accumulators. That at the same time, we also saw legislation in Colorado during a special session that was seeking to essentially codify AFPs or kind of give them some type of like statutory spot in law where they exist that they can point to. Where do you see the policy and advocacy landscape on this going? Do you think this is going to be like one of the next frontiers for patient advocacy? Do you think it's going to be just one more thing that we all have to do to push back, or how do you see that?
Yeah, so at the state level, I do think it's a little bit challenging. I think that the good news with Indiana and Maryland is it shows that legislators are open to looking at this issue and understanding how they can be helpful in addressing it. State law typically only applies to individual and small group plans and large group plans that are fully insured. So it doesn't capture the larger self-insured market. And that's kind of been the standard quo for a while, but there's actually been some really interesting litigation out of Iowa, where a federal district court said that Iowa's copay accumulator ban does actually apply to ERISA plans in the state because the copay accumulator ban was about an administrative mandate about how copay assistance was counted and not a change in benefit design. So while we're seeing, I think, these initiatives in Indiana and Maryland of state legislators to go farther and take state legislation further to address some of these employer-sponsored health plans, we're also seeing a recognition by the courts that this may be something that they're open to considering and making more permissible and broad. So I do think since state legislators are interested in these opportunities, it's definitely something we're going to have to look out for next year. I think, but we also saw that Colorado bill, like you mentioned. So there's also some definitely education we need to be doing with state legislators to make sure they're aware of what these programs actually are. I think the Colorado bill was really interesting because we don't typically see a codification of an existing practice as being legal. We usually say things are illegal in law, not affirm that they are legal. But there are good signs in that bill that there was reporting requirements for brokers and PBMs who were trying to pitch these programs as to what they're allowed to say. There was a recognition that a breach of any of those disclosure requirements would be an unfair and deceptive trade practice under state law. And there was financial penalties for breaching of the law, which are really important in terms of an actual deterrent of the law. So I think there's a lot of opportunity next year. I think we have to be careful that we're crafting the law in a way that courts can uphold it as administrative mandates and not benefit design mandates. There definitely is a lot of opportunity there, as well as I think continued importance of advocating at the federal level for broader change.
Perfect. Thank you. Well, not perfect, I guess. It's a complicated picture, but I know you have some solutions here. So that is really helpful. Thank you, Ashira.
Thanks so
I
much.
did then want to turn to, I almost called you Kathy because I'm thinking about Kathy. I'm looking at her on the screen, and I'm going to be turning to Kathy next. Kathy is the CEO of the Pontchartrain Cancer Center and also the Coalition of Hematology and Oncology Practices, also known as CHOP. She also works with the Community Oncology Alliance, I believe. Kathy is everywhere and on everything. So, Kathy, I'll ask you to introduce yourself a little bit more and some of the work that you do, but also please help us a little bit more on what the Pontchartrain Cancer Center is and also what CHOP does.
Okay. Well, thank you for having me today. I'm Kathy Oob. So my day job is the CEO of Pontchartrain Cancer Center in Louisiana. We're a 3-location community oncology practice that serves patients. Actually, Jen Laws is one of my neighbors. He's 30 minutes from me. But, we serve, patients with, oncology and blood cancers in Southeast Louisiana. In addition to that, I am on the board of the Community Oncology Alliance, COA, and I co-chair their Drug Policy and Regulatory Affairs Committee. And then I'm also the president of CHOP, which is the Coalition of Hematology Oncology Practices. We are an administrative organization, so not clinical, and we provide, a voice for community oncology practices. We currently have right at 40 community oncology practices across 19 states. So that's kind of, some of what I do in a nutshell.
Wow, that's a lot. You don't have a lot of time on your hands, I suppose. So I wanted to talk a little bit about 340B,
Mhm.
and the way we phrase this question is that not everyone has heard of 340B, though unfortunately, if you've been really involved in patient advocacy, you probably have heard of 340B because it's been everywhere all the
Mhm.
time, it seems, the past several years. But for those who haven't, can you explain in a nutshell what the program is, what it was initially designed to do, and then also what its impact is today? And in particular, with the focus, with your experience, how the impact on community oncologists and the patients that they serve.
Sure, happy to. So the purpose of the 340B program, it was created by Congress in 1992 with the idea to help safety net providers stretch scarce federal resources as far as possible to reach more eligible patients. So that was the theory behind it. So it required pharmaceutical manufacturers to provide drugs at a discount, usually between 40 and 60% to those covered 340B entities. And the idea behind that was, kind of buy low, sell high, and you would use that margin in between to support patient support programs and community programs. So that was the theory. It has an and then, the program, what are those eligible entities? So rural hospitals, federal qualified health centers, and your disproportionate share hospitals. So that is the theory behind it, is to, stretch those dollars so they can provide care to more patients. Of note, independent community cancer centers such as Pontchartrain are not eligible to participate in that program. And, one of the primary impacts is it puts cancer centers in the community at a serious competitive advantage. So what we've seen over the years, because, I am old enough to, I don't want to say I've been around because that sounds bad, but I have certainly seen the change in our cancer care landscape since Pontchartrain opened back in 2005. When we started in 2005, there were probably 20 community oncology practices across the state of Louisiana. Over that period of time, because one of the bigger impacts of the 340B program is practice consolidation. Pontchartrain is probably now one of 5 community oncology practices sitting in the state of Louisiana. And why is that? So, 340B hospitals have a financial incentive to acquire independent oncology practices and those patient revenue streams. Back in, I think it was 2014, the NIH published a study that reported that 340B hospital employed oncologists generate about $1 million annually in revenue for their hospital. So consequently, it's business practices such as the one I just mentioned, which contributes to that, shift in moving patients and providers from the community setting into hospital settings, which, by data are also more expensive sites of care. It also has increased competition. So, the expansion of 340B entities in our area and their abilities to acquire or affiliate with smaller practices has really intensified the competition. And we see that certainly in the areas that we serve. There are economic pressures. Community practices such as ourselves, you know, which often provide, you know, a significant amount of charity care. We can't afford to offer chemo, at these full prices and compete with the hospitals that benefit from these discounts. Sometimes these disparities force many community oncologists to either close or be bought out. And, the data has also shown that when you move patients from community oncology into these hospital outpatient centers, you also see healthcare dollars increase. There have been multiple studies that have shown that the cost for oncology service is significantly higher at 340B hospitals compared to non-340B hospitals and community oncology centers. In part because, again, hospitals are reimbursed for administering more chemo in that buy low, sell high mentality. So, there's an impact in community oncology. Those of us who have been around for a while, we've certainly seen, my pediatrician used to be, in a standalone building, right down the road from the house. And for a lot of us with grayer hair, we do remember going to our physicians in their own standalone clinics. And over the last, 20 years or so, that landscape has changed considerably. And where did all those physicians go? They didn't all retire and go to the Bahamas. Many of them are now employed by hospital systems. So higher cost of care, but it also creates access issues because sometimes those hospitals no longer sit in the communities that patients need. So we're creating access issues, by issues of transportation. So we're also seeing impact on the patient, so increased costs. Because, despite receiving drug discounts, the 340B hospitals are not required to pass those savings down to the patient. In fact, some 340B hospitals charge patients and insurers more for the same medication, which can lead to higher out-of-pocket costs, higher site of care costs. So that shift in care from community offices to those outpatient hospital departments often result in higher costs for patients and insurers. And, there's some limited evidence on whether this is increasing, charity care across the US. So many critics point out that, the 340B hospitals are not required to report how they use that revenue from these discounted drugs. And many studies are showing mixed results that, participation doesn't necessarily increase care for these lower income populations. And in fact, some 340B hospitals provide less charity care than similar non-340B hospitals. So then, we have potential barriers to care. Some accounts are even alleging that certain 340B hospitals create barriers that, prevent low income and underinsured patients from accessing care. And lastly, there's no improvement in survival rates. There are some studies out there that suggest that the increased prescribing of drugs in supportive care under the program has not shown meaningful evidence of improved patient outcomes. So there's all of that. And so, despite all the controversies, we do see call for 340B reform. The debate around the program centers on its rapid expansion and whether its benefits align with the original intent to help vulnerable patients. So, calls for reform are focused on, increased transparency, increased oversight, and clarification of the rules. So I'll stop for now.
No,
That's
well,
a
that I
lot to
mean,
unpack.
yeah, I mean, you you described how, it's one of those things where I think it's, 340B, whether you've heard of it by name or not, many people have experienced the impacts of it. You described so many of them just now. You also, I think, went a lot towards, right now, there's a lot of casual observers might see this as a fight between like big pharma and the hospitals, or some of the oncology practices in the hospitals, or whatever.
Mhm.
But I think you really just did a good job of describing the impact on patients, and how this is a program that was designed to, well, I guess you could say that direct impact was designed to provide financial assistance to hospitals, but it's almost like they're misinterpreting it as it was designed to benefit hospitals, and it's not. Even if they were intended to get the economic flow of money from it. It wasn't designed to
Mhm.
benefit them. It was designed to give them assistance so that they can benefit patients, because that's really what this is all
Correct.
supposed to be about. And
Yes.
so, yeah, I guess I was just going to ask, what are some ways where you can see it really not work for patients right now, and how can we change that?
So, the calls for reform that I see focus on increased transparency. So,
Hmm.
greater reporting requirements on how 340B revenue is used, and improved oversight, calls for enhanced regulatory authority to enforce these program requirements, and clarification of the rules. I want to see better definition of a patient and the role of contract pharmacies in the program. But I'd also like to talk about, I'd like to drill down into the patient a little more, because, there was a very notable study or an article in 2024 by the New York Times that highlighted, the Bon Secours health system and Richmond Community Hospital. Richmond Community was started probably 4 decades ago in the east side of Richmond, which is, a predominantly Black community that and they have lower socioeconomics. And so by nature, they qualified for 340B. Bon Secours came into that area, acquired Richmond, and what they saw over time was that Bon Secours essentially started slowly depleting Richmond Community Hospital of its resources. It started with not replacing, X-ray machines, MRI, PET scanners, and then it closed their ICU. And what it did then is it started moving all of those service lines, including infusion, into the wealthier zip codes. And so you take, Richmond Community current day, and it's essentially, a glorified ER. And, the patients that, it's a direct impact to the patients, because a lot of those patients don't have transportation. So there were countless, you know, interviews with these patients that then, rather than be able to, go to where those sponsor corps had moved those sites, they're simply deciding not to seek care. And, my argument to a lot of people is, the Bon Secours story is not unique to Richmond. There's a story of Bon Secours in every state and in most communities across our nation, if we just look hard enough. In Louisiana, one of the sites that we have is our most rural site. We have, in that area, we have about a 1% illiterate rate, and it is primarily, you know, Medicaid. There is a 340B entity there, but they don't infuse care in drugs, but we do. We go up there and we care for those patients. Due to these pressures, if we were to close, the nearest 340B entity or any, oncologist that has the ability to infuse is 45 minutes each way. And, we've talked to our patients, and a lot of them it would be a true access issue for them to be able to drive that 45 minutes each way, because it's not just the patient also. A lot of times these cancer patients are relying on caregivers or friends or loved ones to bring them to those appointments and back. So we would have a true access issue if Pontchartrain no longer, was able to serve that area. And if you'll indulge me, Brian, I'd also like to talk about, the North Carolina Treasurer's Report
Please
because
do. Yeah.
it's not just, a hospital issue. So last year, unbeknownst to all of us, the North Carolina Treasurer republished an amazing report on 340B, and I recommend it for everyone, some light bedtime reading, because they were facing a multi-million-dollar budget problem. And so they looked into how 340B impacted the state, the taxpayers, and the state health plan. And what they found was that the 340B hospitals build the state health plan about 5.5 times more for their drugs than their acquisition cost. So to put a finer point to that, the 340B hospitals in North Carolina generated an average spread of $13,600 per patient per claim. They also looked at non-340B hospitals, and they were able to determine that those entities billed significantly less in claims cost per patient. Again, proving that the problem is not universal to hospitals. There is a decent disparity between 340B and non-340B entities. And so one of the things that they concluded was that, patients, taxpayers, and state employees are paying those inflated costs while hospitals pocketed the spread in that state.
Wow. Well, that is well. I don't know how if I can promise I will read it as bedtime reading, but I think part of the report I usually need to be a little more caffeinated when going over one of those. But I think that it is that we hear I think a lot of stories, and to be able to see them documented in reports like that is eye-opening. And in terms of not just the impact you said, like you said, to patients, but also to everyone, whether because a lot of what we look at is, and we'll talk a little bit with Jen about this. I'm starting to transition here on the next speaker. But as we look at like overall healthcare system costs, in addition to kind of individual patient costs, this is something that is also ballooning everything. So it's making patients poor, but it's pay more, but it's also making everyone else pay more.
Yeah.
So thank you, Kathy. And with that, I will turn now to Jen, who is the CEO of the Community Access National Network. Jen has served as president CEO of CAN since 2002. He's a community-based advocate through
2022.
2022. I'm sorry. I'm like,
I
yeah,
would have
small font. It was red.
Turning 40 next year, man. You can't push me that hard.
I won't. Good to see you again, Jen, by the way. So and we'll talk a little bit more, I think, probably in some of the later questions about the PDAB and how they balance system costs with individual patient costs, which is what I was getting at earlier. But Jen, if you can first describe a little bit about CAN, your mission, and how you work to improve healthcare in the communities that you serve.
Thanks, Ryan. I appreciate that. CAN turns 30 next year, which is just a giant deal. So in 2002, the board appointed me to this spot, and I had been working with CAN for a while. CAN defines its mission as really kind of advocating for the policies and programs that support people living with HIV, hepatitis C, or substance use disorder from the patient perspective, right? So all of these things are well and good, that we know where these communities need things and all that, but actually creating an ecosystem of access is where we focus on. It's why access is in our name, right? So we've got some really interesting perspectives, historical successes that are currently under attack, and a broader kind of assessment of the ecosystem that patients interact with. So whether it's with payers and insurers, whether it's with government programs, state programs, federally funded, regardless of what it is, whether it's interacting with providers, provider entities, the whole range of things. Like we try to assess that and then say, hey, this is where patients are experiencing either hardship or success, right? Because ultimately, if we're going to talk about healthcare as measured by patient success and experience, then patients have to be leading these solutions and conversations. We work across the ecosystem to the best of our ability with public policymakers, with manufacturers, and to full disclosure, manufacturers are the sole current like entity type that funds can, primarily because I will not ask for dollars from a community that is already highly impoverished. That just seems very unjust to me, and improper, and also give me some of my money back. I am very direct, right? Like that. I'm proud of those relationships that we have. We do have a decent network of providers and provider entities that we work with, as well as other government programs, public policy officials. Like we just, how do we get everybody to the table? And I'll tell you, the folks that refuse to come to the table are often hospital administrators and payers. So that kind of says a whole awful lot about where priorities end up landing. So there's that. We've dealt with 340B, we've dealt with PDABs, we've dealt with Medicare, Medicaid, like anything that touches a patient, specifically patients living with HIV, that's where we're going to be. We also recognize that the experience of patients living with HIV can be applied broadly across certain socioeconomic and demographic situations.
Thank you. And I think it was with the on some of the PDAB work, and specifically probably not long after you started in 2022, not 2002, that in Colorado with their PDAB that you and I first worked together, had an opportunity to work together. But you've been working across the country to ensure patients have a voice in PDABs. They, exist now in Oregon, Washington, Colorado, Maryland, Minnesota. Those are the ones that have like kind of more like a serious body of law surrounding them. But what have you, since you've been engaged in so many of them, what would you say that if there's one thing that legislators who are considering these bills, as well as perhaps those who are supporting them, if there's anything that, what do they get wrong about this issue? Because I feel like we've seen these, they're not, I mean, I maybe I'm opening up a cliff there, I guess, but if I could summarize everything, it's like they're not serving patients right now, and that is becoming increasingly clear. So if there's the number one way that you would say that these people are getting wrong when they say this is the solution, what is that?
I mean, they're getting this wrong in every way, right?
Okay,
The
fair.
entire
Yeah.
design behind a PDAB is really kind of the issue, in part because it favors the perspective of payers. To that end of saying, hey, if we just reduce the allowable top end in which you can reimburse a particular medication, we're going to actually, I anticipate we'll start to see this kind of occur around providers as well. So big red flag, everybody, in part because the folks that are sponsoring these bills have already said that's what they're going to do. Like they passed around a paper about it. Thanks for broadcasting where we need to be paying attention. But it says if we cap the allowable payment or reimbursement to a certain degree through the payer, then maybe that'll reduce costs with regard to medications. But there's no, like, in theory, it says, hey, absolutely, I can go ahead and forward the screenshots I got from somebody inside of an event. Thank you, David. And we'll send that through bio. Essentially, if you can cap that payment, then in theory, the insurer will then reduce the costs around benefit design and whatnot for patients. But there's the way, because of all of the problems around PBMs and how they're exploitive and extracting value away from patients, that doesn't really functionally work that way. It also doesn't take into consideration, pharmacy costs of acquisition. It doesn't take into consideration any of the price concessions that already exist by PBMs. And it doesn't take into any of the issues related to 340B, for example, for when 340B is working the way it's supposed to. And we have a very specified interest around that. And please bear with me, Brian. Ken got involved on the PDAB issue specifically because of 340B's support for the AIDS drug assistance programs. For those unfamiliar, AIDS drug assistance programs are state-based but federally funded, and worked through the Ryan White HIV/AIDS program to provide no-cost medications to patients that are enrolled in it, right? On average, across the country, 47% of ADAP programs are funded through 340B. So if you cap that reimbursement rate, then we don't get the spread, we can't do the reinvestment, and then we start to see degradation of the ADAP program, right? And that means that you're not directly helping patients. And I want to say ADAPs are gold standard in 340B. Those dollars are directly passed through to patients for no-cost medication, right? Like that is the way it should be. Like we can see a direct benefit, and it literally exists not like that in any other grantee or covered entity in 340B. So we've got to hold up the standard. We actually do need to keep this in place, but a PDAB is going to decimate that, right? We would also see a PDAB negatively impact the Medicaid rebate drug program, right? So Medicaid gets rebates. There's mandatory rebates in every state that then are reinvested into the program to reduce both state and federal share costs associated with it, right? So there's all of these mechanisms. If a pharmacy can't afford to, because of the reimbursement rate, can't afford to acquire a drug, how is a patient going to get a drug, right? How does that not further drive the desertification of independent pharmacists, right? How does like these access issues suddenly get much bigger? Because the problem for patient affordability isn't the reimbursement rate, is the plan design. So that's the piece. And I promise when I'm in front of a legislator, it's a 15-second pitch, not me going off like a crazy man.
And are you seeing legislators that are they understanding that argument? Are they understanding the difference between, the cost of like you just said, like what's a patient paying, what's the cost for them versus what's the cost for the system, is how not fixing a reimbursement issue between a hospital or other provider and a health plan, how that doesn't benefit patients? Is any of that breaking through?
We're getting some of that around some of the PBM reform push, which we're also involved in, right? Because we think that's a more direct way to solve the patient affordability concern. We also think it addresses state spending concerns, right? Like this is also a budgetary piece. If PBMs are not exploiting these programs for what they are, then state budgets will also go down as well. Speaking to Kathy's mention of the North Carolina Treasurer's report. So there's that, and we get some push on that, but the entity that is funding this push also has deep relationships with AARP and other advocacy organizations. They also do other supposedly philanthropic giving to states to the tune of many millions of dollars. So legislators are not necessarily incentivized to push back against that without some kind of deep dig in, right? So tying this with PBM reform has been quite useful to us. Tying this with sustainability of Medicaid is quite useful to us. But generating the data around that's kind of hard because PDABs kind of function on a theory, right? There is no evidence that there is benefit to patients. Indeed, what we do know about how the ecosystem works is it would be quite detrimental to patients. But even getting legislators to nail down defining the word affordability is insane. It's impossible. These boards don't define, quote, affordability. So what are you actually aiming for? It's not outcome-based efforts, right? It is a sledgehammer in a very fragile ecosystem. So it's quite frustrating to deal with, but we are getting more traction than we used to. However, there's a problem. The way this is going, because I remember the prompt questions. The way this is going, while we anticipate seeing a PDAB pop-up, legislation pop up in Virginia, there's a shift. The folks pushing behind this have realized that we're actually really good at slowing down these boards to consider the actual patient experience. So they're moving to reference pricing as an effort. There will be a substitution in states that have looked to implement a PDAB to just say, hey, we know that the Medicare drug price negotiation piece is out there, but we want to apply that to all drugs across all commercial plans and everything else, which has the same effect as the upper payment limit that PDABs do, but none of the actual process that cares to even pretend that it cares about the public. It's quite offensive to me, but that's what folks need to be looking out for. Reference pricing is coming like a train.
And it's interesting because I feel like we've seen, maybe 4 years ago or so when we saw some of the first PDAB bills really moving around, maybe six, I guess, 4 to 6 years ago. A lot of people were kind of quiet. And they were new concept, like you said, that's very theoretical. But now we've seen New Hampshire just repealed their PDAB this year. And I think also the level of where, like, if it's a drug pricing issue, it's a lot of times it's legislators trying to address an issue, and mostly it's the pharmaceutical companies up there. That's our job. But now the patients are more here seeing, because I think they've seen how this works.
Mhm.
And if you're at the Colorado or Maryland or Oregon PDAB meetings, not the legislative hearings, but their actual board meetings, it's mostly patients talking about, hey, wait a minute, we're seeing this and we don't like the direction you're going in. Are you
It-
seeing that that's, in addition to perhaps maybe some strategic differences of legislators saying, or the proponents of this saying, well, rather than do a stakeholder process, let's just do MFN or, either most favored nation, maximum fair price, whatever. Apparently there's a lot of MF, fill in the blank acronyms for drug pricing. But are you seeing the debate shift on this at all, or is it just still more digging in deeper and they're trying to push for it in these
depends on the
streamlined ways
state.
almost?
It really depends on the state. And I want to be clear, patient advocacy organizations are highly involved in these board meetings, but whether the boards are actually paying attention to them is an entirely different issue. Maryland is a mess, guys. If you ever go to one of these things, it's an absolute mess. They're like, here's your minute and a half. Hope you said something. We're not paying attention. It's rough in Colorado and even in Oregon, less so in Oregon. Oregon's got, in part because they had a change in their chair to a community pharmacist, somebody with a community pharmacist background and a public health background. So she actually really does care about patient experience. And so we've had a bit more progress there. But in Colorado, it is 4 to 6 hours per meeting, which I don't know how many patients actually have that much time. And there's a lot of hostility toward patients. Oh, you're funded by manufacturers. Well, yes, I am funded by manufacturers, and it's quite useful because they pay CAN enough money that they actually care what we think, right? So yes, I'm going to keep taking their dollars, but let us not pretend that the other stakeholders at this table, hospitals, payers, anybody else, don't have a financial interest as well. Indeed, we're talking about patient financial interest to begin with. So let's go. We've had those conversations. We've had some traction across being able to emphasize 340B and public programs impact. But we've not had a lot of actual in-depth they are in the we have to do something phase. And legislators are very much the same way. This is true across all legislators. They want to pass a bill, but the level of oversight and engagement that comes afterwards to make sure it's actually achieving what it's supposed to is almost non-existent. And we see it from the federal level to the state level. So I'm quite frustrated by that. We've gotten to actively engaging with state legislative offices to say, hey, did you know that this board's behaving this way? In part because it's necessary, right? Making sure that we're closing that loophole or that loop, as it were, to make sure they know what's going on. When the Colorado PDAB says we don't know that this is actually going to be beneficial at all, while we're talking about the well-anticipated access issues, legislators need to know about that, right? Like, my friends, y'all put this out here. Do something about it. It's not going to do what you asked. And now we've got some evidence for it. Part of why New Hampshire repealed their PDAB is because it's useless and it costs the state several $1 million to run with zero results over 3-4 years. And we're pointing that out too. I think we're going to have decent traction in potentially getting the PDAB, like the budget pulled back to a nil in Colorado next year. And Brian, you and I can talk about that offline if you like.
Okay, we will. Yeah.
Yes.
Okay, so thank you, Jen. And we, as we mentioned at the very beginning, we had one panelist who wasn't able to be here today. So I think we had the luxury, each of us were able to speak a little bit longer, but I think we'll also, we had about 5 minutes planned for Q&A, but maybe we can do closer to 9, I guess now. If that's okay, then Karen, I don't know if you would like to moderate the Q&A or call on people, or if we can just invite people to raise their hands.
Absolutely. Maybe I will take the prerogative of the first question. So please, everybody, get your questions ready. We have about 9 minutes or so left. Listening to our three panelists and thinking about, in particular, the state sessions that are coming up sooner than we can probably think, understanding we are approaching the uh, end of the year. I would love to ask our three panelists and you, Brian, like how should patient advocates think about next year, all the challenges that are coming up in the states, and where can patients get engaged and learn more?
So I think that we are in the patient advocacy ecosystem. We're all very good at duplicating each other's work. What I mean by that is we see the same problem, so we put it out in different languages, and there's a lot of capacity that's taken by that. I think we need to stop doing that. I think we need to look at what we're good at. I think we need to engage with our partners when they need warm bodies in a space, spend more time making sure that presence is known. And then elevating the voices who are experts in a particular area, because this is going to be a hard and fast session. A lot of correction efforts around HR1 are going to be going on, and states are going to overreach and overshoot where they should be in terms of what's effectively valuable for patients, in part because hospitals are losing their minds. Insurers are losing their minds because we're seeing PBM reform efforts. Like, we've got to figure out how to be a bit more strategic and to maximize the value of our capacity, especially when it comes to physical presence.
Any other advice? Shira, you'd mentioned the task force, and I know there's a lot of, as you mentioned, AFPs cropping up. How can patients get involved, and what should patient advocates expect, kind of on your front?
Yeah, I think Jen made a great point. I think there's a lot of us, but we have to kind of figure out where we have our expertise. And I think the task force does a really good job of kind of pulling all the people who are worried about AFPs together so we can kind of talk with that singular voice and kind of figure out where we can be most impactful. So I would encourage any groups who have patients who have experienced harms with AFPs, who maybe aren't even at the stage where they're willing to publicly talk about what's happened with their experience with AFPs, but to reach out to the task force. You can reach out to me at Aimed Alliance or Kim Zubark at Cancer Care, just to talk more about your story, figure out where we can share it, whether that's with your state legislator, with your federal legislator, but just getting involved and reaching out, I think, is the first step in that conversation for next year.
I think you brought up a really great point. I've heard from several patient advocates that people who get caught up in AFP sometimes are even worried about coming forward. They're worried because of the relationship with their employer and their health plan, etc. And so absolutely, we will make sure to share the information for the task force in our follow-up. Kathy, any other thoughts from you before we open it up for questions?
Sure. So from a patient perspective, the hospitals are not required to notify patients if they're 340B eligible or if they're billing them under that program. So, then the question comes to, why should patients care? Because without transparency and accountability, 340B has a significant risk of becoming a hidden tax on patients and taxpayers, and then patients may face higher copays and reduced local access. And, if patients want to get involved, tell their story, there's two groups that, I do work with. One is Patients Rising, and they have documented a significant number of real-world patient stories of high out-of-pocket costs despite hospitals getting these 340B discounts. So, there's that warning that the program is drifting, into a revenue stream for institutions rather than, relief for patients. And there's also another one called Tiger Lily Foundation. So they do a good job of highlighting how underserved patients, especially women of color, are left behind when hospitals cut local services and expand the 340B sites into more affluent areas. And so, if you know a patient or if you are a patient and you're looking to learn more or get involved, I would certainly, reach out to those two organizations without a doubt. And then if you're a complete nerd like myself and you're learning to, read more, Pioneer Institute has a great website and they regularly update it. Growth of the 340B program, legislative mapping, hospital charity care, and then state one-page fact sheets if you're ever looking to, meet with your legislators. And then for the super nerds, myself included, McDermott Plus has a regularly published 340B blog called Regs and Eggs. And it tells you kind of what's going on as a microcosm within the nation.
Well, and I would say keep an eye out for folks in states that haven't already passed 340B expansion bills under the contract pharmacy lens. They'll be coming, but there's also federal action that's occurring under the 340B Access Act. So there are plenty of opportunities to engage on the 340B level. And even if it's only just come be a friend, warm bodies in a room matter. So
yeah.
Fantastic. Any questions from the audience? I know that was a lot to absorb.
Well, and I would emphasize that because that's a lot of information. I know that I'm available. I know that Kathy's quite available, and Shiri, I don't want to speak for you, but maybe I'm going to presume that we're available for follow-ups if somebody's taken notes and they just want to be able to converse.
Oh, yeah. Have a question of what's next.
Fantastic.
Yeah.
And not seeing any other questions. Maybe Brian, I can ask that question to you too. On the patient access side, what are some of the things that you and your team are watching for next year? And where can patient groups plug in?
Wow, we're looking at a lot of things. I'd say, right now we're considering another busy year on 340B. We're looking at a number, I mean, really some of which is relevant to today's discussion. PDAB legislation. Jen mentioned earlier that Virginia is a state that has twice passed PDAB legislation, and it's been vetoed, but we're going to have a new governor next year, no matter what. So we anticipate the legislature to be interested in sending something to the governor's desk. There are, we saw, well, this year, as I mentioned, there was some positive movement in terms of banning AFPs as part of the accumulator maximizer bans that passed in Indiana and Maryland, I think it was, as I said. We've also seen now the Colorado bill. So think that seems to be heating up. Our team does a lot on vaccine issues. It's not controversial at all. No, the vaccines have not been in the news lately, so I'm sure there will be nothing on that next year. But it's going to be a busy year. So Karen, when you started to ask this question, you said, "What can everybody do to prepare?" My first thought was we can all try to rest and sleep right now because come January, when those legislatures get into session, it's going to be a busy year on a lot of issues for us.
Fantastic. Thank you all so much. I know in this hour together, we've barely scratched the surface when it comes to access challenges for patients in the states, let alone federal and state issues. So one last plug, just reminding everyone again of our October summit, October 26th to 28th in Washington, D.C. I hope to see you all there. And thank you so much for joining us for our September coffee chat. An incredible thank you to our amazing panelists and to you, Brian, for expert moderation. And I will hopefully see you all soon. Thank you so much.
Thanks so much.
Thank you. Have a
Thank you,
great
everyone.
day.